Imagine a 22-year-old patient comes to the emergency department after a road traffic accident. He has severe pain in left upper abdomen and his blood pressure is falling. And then he suddenly says, "Doctor, I have severe pain in my tip of my shoulder." Now here is the interesting question. Why should an injury inside the abdomen causes the pain in shoulder? And even more importantly, why the spleen is vulnerable to injury? Why does the spleen lie exactly where it does? Why does it have the characteristic long axis? And why do we keep hearing about 10th rib, 9th and 11th ribs, splenic artery, splenic vein, Kehr's sign and splenic segments? By the end of this lecture, all of these facts will connect to one picture, and so let's understand the spleen not by memorizing it but by actually visualizing it. Before we start this, understand why this organ is important for your MBBS exam. Spleen is very common anatomy question and you have been asked about its location, external features, relations, ligaments, blood supply, lymphatic drainage, nerve supply functions, vascular segments and clinical anatomy. The clinically spleen becomes extremely important in trauma, splenomegaly, splenic infarction, Kehr's sign and blood disorders. So don't treat spleen as a list of facts. We are going to build it like a three-dimensional organ. First imagine it lies in the hypochondrium and partly in the epigastrium here. And it is positioned between fundus of stomach and diaphragm. And it is positioned between why is it location important? Because the spleen is not sitting randomly. Its position is closely related to diaphragm, stomach, kidney, left kidney and splenic flexure of colon. And this will explain almost all of its visceral relations later. Let's see the dimensions. Normally spleen is 9 to 14 cm long, 6 to 8 cm broad and thickness is about 3 to 5 cm. Its average weight is about 150 grams and it is a soft, highly vascular, normally not palpable in the healthy adults. Now here is the important clinical point. If the spleen becomes enlarged enough to become palpable, don't just think, okay, spleen is bigger. Think what the direction it enlarged. We will come back to disease and we will discuss it, splenomegaly, after. Now look at the long axis of the spleen. It's not a vertical. The spleen lies obliquely along the long axis of the 10th rib and its axis is directed downwards, forwards and laterally. It makes approximately 45 degrees with the horizontal plane. Why should you remember the 10th rib? Because a single fact helps you to understand the normal position, splenomegaly, clinical examination and even direction in which enlarged spleen moves. So instead of memorizing 10th rib, imagine the spleen as a lying along the 10th rib. Now let's physically examine the spleen. Now easiest way to divide the external anatomy into two ends, two borders and two surfaces. And there is one important feature called as the hilum. First we will discuss the two ends. Anterior end, it is expanded and directed towards the forwards and it reaches toward the mid-axillary line. Posterior end, it is the more rounded and it directed upwards, backwards and medially. Opposite. So remember the direction. Anterior is downward and forward. Posterior is up, backward and medial. Superior border is characteristic because it contains notches, especially near the anterior end. These notches are clinically useful because they help us to identify the enlarged spleen during the abdominal examination. The inferior border, in contrast, is the rounded. Here we will see about the surfaces. First is diaphragmatic surface. It is smooth and convex. Why? Because it is molded against the diaphragm and rounded the diaphragm. The spleen is related to cardio-diaphragmatic recess of pleura, lung and 9th, 10th, 11th ribs on the left side. Now the second surface is completely different. That is the visceral surface. It is the concave and irregular. Why irregular? Because several abdominal organs are pressing against it and producing characteristic impressions. And this is where the spleen becomes very interesting. On the visceral surface, think of four important impressions: gastric, renal, colic, and another is pancreatic. First, gastric impression. This is produced by fundus of the stomach. It is largest and most concave impression of the spleen. It lies between the superior and intermediate borders. Why is this important? Because the spleen and the stomach are closely connected anatomically by the gastrosplenic ligament. And so, whenever you see spleen and stomach together, think gastrosplenic ligament. Second one is the renal impression, and this produced by the left kidney. It lies between the inferior and intermediate borders. So, gastric leads to fundus of stomach, renal leads to left kidney. Third one is the colic impression, and this is related to splenic flexure of the colon, and it occupies a triangular area near the anterior end of the spleen. This its lower part is related to phrenico-colic ligament. Fourth one is finally pancreatic impression. This is produced by the tail of the pancreas. It lies between hilum and colic impression. Next we will see about the hilum. Hilum is present. Here is hilum. It is present on the visceral surface. Think of it as a doorway of the spleen. Through this doorway, structures enter and leave the organ. The hilum transmits the splenic vessels and splenic nerves and provides the attachment for the spleen, gastrosplenic and splenorenal ligaments. It lies in inferomedial part of the gastric impression and along the long axis of the spleen. So, if someone asks you where does the hilum of the spleen, don't just answer visceral surface. Think visceral surface, gastric impression, and inferomedial part along long axis. Now let's answer the important question: how is the spleen is held in its position? The spleen is essentially intraperitoneal, covered by peritoneum except at the hilum, but it doesn't simply float inside the abdomen. It's suspended by important peritoneal ligaments. Let's see. First, the gastrosplenic ligament. Stomach plus spleen. Name suggests that it extends from the hilum of the spleen to the greater curvature of the stomach, and it contains short gastric vessels, lymphatics, and sympathetic nerves. Second one is splenorenal ligament, also called as Splenorenal ligament. Extends from hilum of the spleen towards the anterior surface of the left kidney, and this ligament is clinically important because it contains tail of pancreas, splenic vessels, pancreatico-splenic lymph nodes, lymphatics, and sympathetic nerves. Now notice something, that the tail of the pancreas actually reaches the splenic region. That's why this is spleen and this is the tail of the pancreas, and that's why pancreatic disease and splenic anatomy can sometimes become closely related. Now the third one is slightly different, that is phrenico-colic ligament. It not attached directly to the spleen, but it supports the anterior end of the spleen. It is the horizontal fold of peritoneum extending from the splenic flexure of the colon and diaphragm. It is diaphragm, and it lies approximately opposite the 11th rib near the mid-axillary line, and it forms upper limit of the left paracolic gutter. Imagine the phrenico-colic ligament as the small shelf underneath the spleen, and the spleen rests partly on this shelf. Now comes one of the highest yield areas, the blood supply. Blood supply of the spleen, it is supplied by the splenic artery, and the splenic artery is the largest branch of the celiac trunk. But there is something special about the splenic artery is it is tortuous. Why? Because the spleen can change its size, position some extent, and tortuous artery can accommodate movement better than the complete straight vessel. The artery travels through the splenorenal ligament to reach the hilum and 5 more segmental branches, and this is extremely important. Let's see about the vascular segments. Inside the spleen, these arterial branches behaves like a separate territories, and there are generally superior and inferior vascular segments separated by approximately a vascular plane. Why it is clinically useful? Because these segments allow the surgeon to remove only diseased segment of the spleen in the selected situation rather than removing the entire organ. This is called the segmental resection, and this is the favorite university exam question. Describe the vascular segments of the spleen and its surgical importance. The key phrase to remember that segmental artery is relatively avascular plane and segmental resection. Now let's come to the venous drainage. The splenic vein is formed at the hilum. It runs relatively straight course behind the pancreas, and then it joins the superior mesenteric vein behind the neck of the pancreas and togetherly form portal vein. Splenic vein plus superior mesenteric vein forms the portal vein. Tributaries of the splenic vein include the short gastric veins, left gastroepiploic vein, pancreatic and inferior mesenteric vein. So here is very useful clinical correlation that splenic vein and portal vein. Therefore, disease affecting the portal venous system can have consequences with the spleen. Now let's quickly understand the lymphatic drainage. Lymphatics begin around the periarterial lymphatic sheaths, that's called as PALS. Within the white pulp, they travel along the trabecular vessels towards the hilum. Lymphatics from the subcapsular plexus also move towards the hilum. From the spleen, lymph ultimately reaches the celiac lymph nodes through the pancreatic and pancreatico-duodenal pathways. An important point, there are no lymphatic vessels in the red pulp. Here we will see about the nerve supply. Sympathetic fibers come from the celiac plexus and their major function is vasomotor control. They also supply smooth muscle present in the splenic capsule. Now let's answer the most basic questions. Why do we even have a spleen? Think of the spleen as three things, that is blood filter, immune organ and blood reservoir. Removal of the old RBCs. The spleen removes old and abnormal red blood cells mainly through the phagocytosis. So think of the spleen as the body's RBC quality control department. Second one is hematopoiesis. During fetal life, the spleen is normally participates in hematopoiesis, but after the birth, these functions normally becomes minimal. Immune function. White pulp is involved in immune responses and lymphocytes responds to antigens and help to generate immune responses including antibody production by plasma cells. Fourth one is the phagocytosis of the microorganisms and other unwanted particles through the phagocytic activity. Reservoir, and finally spleen can act as a reservoir of blood, particularly RBCs. Now let's turn to our patient from the beginning. First one is the splenomegaly. It is the enlargement of the spleen. Normally the spleen is not palpable, but when it becomes significantly enlarged, it can extend downwards and medially into abdomen, and because the spleen's long axis follows approximately the direction of 10th rib, its enlargement follows the general direction. In the massive splenomegaly, it can even extend towards the right iliac fossa. During examinations, notches on the superior border can help identify the enlarged spleen. Second one is splenic infarction. Splenic infarction, remember those segmental arteries. They are essentially end arterial territories, so occlusion of some splenic arterial branch can produce the area of infarction. And repeated infarctions can eventually produce scarring and fibrosis to the spleen. Let's see the Keher sign. Now comes one of the most famous clinical correlation. A patient with ruptured spleen may develop pain at the tip of the left shoulder, but why the shoulder? Blood or the irritation near the diaphragm stimulates the phrenic nerve, and the phrenic nerve carries the fibers from the C3, C4 and C5. The brain interprets these diaphragmatic irritations as the pain referred to the shoulder region. So remember, C3, C4, C5 keep the diaphragm alive, and that's why the problem in the abdomen can produce pain somewhere as a distant as the shoulder. Splenic sequestration. Here is the one of the most important clinical condition. that the splenic sequestration crisis. This is particularly important in clinical conditions such as sickle cell disease, and cell can occur in other hemoglobinopathies. Large amounts of blood become trapped within the spleen. This can cause sudden fall in circulating blood volume and may produce hypovolemic shock if severe. Repeated splenic infarction can also lead to scarring fibrosis. Okay, so we will see the rapid revision, and there are another disease like Bunty's disease, chronic congestion enlargement of the spleen resulting the premature destruction of RBC. Remember for Bunty's disease. And another is splenic puncture. So here are the different diagrams for the visceral relations. Here are the different impressions. Here pancreatic impression, tail of the pancreas nearby this. Here the ends, borders, and colic impression, gastric impression, renal impression, hilum. These are the visceral relations. Pancreatic tail is here. This is the spleen, splenic artery, splenic flexure of colon. This is the left kidney, left suprarenal gland, and this is the stomach. Peritoneal relations are there. This is spleen. No, this is spleen. This is left kidney, and these are the Splenorenal Ligament. Here is the Gastrosplenic Ligament. Short gastric artery, splenic artery is here. This is tail of the pancreas. This is the diagram for the spleen. Normally this is anterior end, posterior end, inferior border, superior border, and notches are there. Hilum contains the splenic vessels, and this is the ridge. And we will see the rapid revision. Let's see. Location, left hypochondrium, partly in epigastrium, shape is wedge shaped, long axis along the 10th rib, direction downwards, forwards and laterally, two surfaces diaphragmatic and visceral. Diaphragmatic surface smooth and convex, visceral surface is concave and irregular. Four impressions, gastric, renal, colic and pancreatic. Hilum on the visceral surface, main artery splenic artery from the celiac trunk, main vein, splenic vein and then portal vein. Important ligaments, gastrosplenic, splenorenal and phrenico-colic ligament. Nerve supply by sympathetic from the celiac plexus, and the famous clinical sign is Kehr sign, left shoulder pain in splenic irritation or rupture. So you should have answer my one MCQ that patient with splenic injury develops pain at the tip of the left shoulder. Which nerve pathway is primarily responsible? That is the phrenic nerve. Because the irritation of diaphragm activates the sensory fibers carried by phrenic nerve, producing referred pain to the shoulder. So, if this lecture helped you to understand the spleen rather than simply memorize it, subscribe because we are completing another topics also. Thank you.